Hello. Welcome to Dental Assisting Week 1 with the Colorado Dental Assisting School. I know you guys are getting super stoked for your final coming up. I know it's a lot of pressure and it's so much information, but rest assured, we've got your back. Your instructors are so excited for you guys. And if you have any questions, you can always reach out to your instructors or myself, or other people in your class are always a good idea for you guys to get together and maybe do a study group or something like that, so you can kind of pick each other's brains. Dental specialties. I know you guys have been waiting for this for a while. This is something that a lot of our students get really excited about. Okay, so let's begin. We're going to start with prosthodontics. Prosthodontics is something that we do in general dentistry every day. So a specialized dentist who focuses on fixed or removable restorations to restore the mouth as a whole. So when we do crown and bridge, that's prosthodontic. That's prosthodontic work. We're restoring the mouth, and we are helping that patient keep their teeth, because we are in the business of saving teeth, and that's really what we want to do. So this picture you're looking at is showing before and after. You can tell that the person's smile was very deep and their bite was very deep. I'm sorry, the smile was very shallow. So not really able to show their teeth like they want to. One, because the bite is so deep that they're not open as much as they should be. So by putting a crown on every single tooth, they were able to open that bite up and, of course, fix the gum line to a healthy level as well. So prosthodontics, they are going to specialize in occlusion. So they do have occlusion-specific training that they follow and attend outside of their normal education as far as becoming a dentist goes and becoming a prosthodontic. They do full mouth rehab. So like the picture you just saw before, a crown on every single tooth, possibly dentures, implants, they can do any of that. So they used fixed or removable prosthetics for restorations. So it could be an implant retained denture. It could be removable appliance, like let's say a partial and it only has 2 or 3 teeth attached to it, and they still have some teeth in there that are healthy enough to keep. That's always an option as well. So basically, when we talked about everything before then, that was all prosthodontic work that we were talking about, that you will be assisting the dentist with. So let's talk a little bit more about endodontics. I know we've mentioned it previously, but we haven't really gone into detail. So get out your notebooks, start taking a lot of notes, because this is something that we do in general dentistry and is very detailed. There's a lot that goes into endodontics. So the endodontist manages the prevention and diagnosis and treatment of the dental pulp. They are going to save that tooth, right? This is our last option before we have to extract. So they're often referred to as root canal treatment or therapy. This specialty provides an effective treatment to save teeth that have been infected or fractured. So it could be they have caries and the tooth gets infected into the pulp, and that could cause it to die, needing a root canal. Or maybe there was some trauma to the tooth and it fractured, which could in turn, again, lead to that dead necrotic tissue inside because of the fracture. General dentists can perform root canal treatment. However, they may refer the patient to an endodontist, and of course that is the dentist who specializes in this area of endodontics, is an endodontist. And a lot of times we will refer to them when it's a more posterior tooth, when it's a molar, because they have canals in the root that we can't see with the naked eye. So they use a special microscope, so that way they can see it and get all of those canals in there, so it doesn't need to end up being retreated later in case one gets missed. So the microscope is a big deal in endodontics, because it helps that doctor make sure they are providing the best possible care for that patient. Pulp damage. So again, this could be physical irritation or some sort of trauma. So the physical irritation is often caused by decay entering into the pulp chamber, bringing in bacteria, right? Causing that nerve, artery, and vein to die. And in turn, it would turn into an infection, which would lead to an abscess. Sometimes the abscess will drain on its own into the mouth, through the periodontal ligament and out of the cemento-enamel junction. And then the patient might tell you, oh man, I have this really bad taste in my mouth, and this tooth is really hurting me, and every time I go to eat anything, it zings me or it wakes me up at night. Those are all indications that the periodontal ligament is swollen, and we really need to get a periapical x-ray of this tooth so we can see all the way at least 3 millimeters past that apex to make sure that if there is an infection in there, it is treated with root canal treatment. Trauma, a hit, any direct hit or hard contact can damage the blood vessel in the tooth, causing it to die. So any sort of trauma, sports or, a glass, a toddler, any sort of trauma to the tooth is going to cause it to die like that. And a lot of times the tooth will turn gray, and there's no pain usually. I mean, it might be a little sore if it gets smacked. Let's say you get hit in the face with a softball, obviously it's going to hurt. But if you accidentally bump it on something and it's just right, you could accidentally damage that blood vessel enough to cause the tooth to die. And once it turns gray, we know that that tooth is dead, and it will start to create an infection and an abscess. So we need to get in there and clean it out and make sure that we can save that tooth. Okay, so once your patient is seated, before the doctor evaluation happens, you are going to take a bite wing and a PA of the tooth that is in question. A lot of times patients are going to come in to the office for what's called a limited exam. And what we mean by that is we are focusing on one area of the mouth only on this exam for this patient. So for the next hour that we have them in the chair, we're going to be asking them questions like, what are you here for today? How long has this been hurting you? Do you notice it distracting you from your work? Does it wake you up at night? Is this a sharp pain? Does it hurt to chew or drink hot and cold? Anything like that. And then, of course, you'll be taking your x-rays. You'll be checking their health history. Let's not forget that one. And then you will go ahead and go grab your doctor and say, okay, we got the x-rays. Patient in operatory 2 is ready. And they present today with, number 3, very painful, swollen, all that good stuff. So you'll give them all the information that you've collected from the patient, which, don't forget, is going into your chart notes. And then the doctor will come in and do an exam. Now, during that exam, you will be taking notes because, again, this is going into the patient's chart. They're going to be checking if there's any decay present, what the extent of that decay is in the tooth, the periodontal conditions. How are they going to be checking the periodontal conditions? They're going to be using their perio probe, and they're going to be paying attention to the outside to see if there's any abscess or blood or any sort of indication that this tooth might be infected, or maybe they have periodontal disease, and we need to address that as well. Our prior restorative treatment completed. So we want to know, does this tooth have a crown on it? Is there some sort of bridge or possibly a filling in there? If there is, does that tooth have recurrent decay? Is the restoration still going to be something we can save, or does it need to be replaced? Tooth mobility. They always want to check for the tooth mobility in case it was in some sort of trauma. So again, we're just checking all these things to make sure we can save this tooth. Swelling. Definitely want to check to see if there's any swelling, because that could equal an abscess. Tooth discoloration, like I was talking about before, the tooth could turn gray once it dies and there's no more nerve, artery, and vein feeding it all of those nutrients anymore. And of course, the pulp exposure, that would be very obvious. And the reason for that is because the tooth would be broken and you could see the pulp of the tooth. In that case, then the doctor really needs to do an evaluation and decide if this tooth is savable or if we are going to have to go ahead and extract it. Pulp testing, this is one of the things that they will do. So the endodontist or general dentist will evaluate and test the expected tooth. They will also use a control tooth or several teeth during the test to compare symptoms. So let's say number 6 is bothering us, our upper right canine. The doctor is going to do a cold test on that tooth. They're also going to do percussion and palpation. But while they do all 3 of these tests, they are going to make sure and test at least 3 or 4 teeth next to the tooth that's in question. So they might start at 3, 4, 5, 6, and go to 7. And each time we go down the line, we're going to ask the patient to raise their hand if they feel any pain. So they're going to palpate, applying pressure to the mucosa above the apex of the root, looking for sensitivity and swelling. Next, they're going to do percussion. The doctor will tap on the tooth in question and multiple teeth to note any discomfort. And again, guys, during this time, you're going to be taking notes. Negative, negative, positive, right? We hit 6. That one hurts. The patient raised their hand. The cold test, the doctor will place a cotton pellet or cotton-tipped applicator with dry ice on several teeth to note the duration of sensitivity. Now, the way this happens is the doctor is going to ask the patient to raise their hand once they feel it. And then once the pain or sensitivity goes away, we all know what cold feels like on our teeth, right? Not fun. But once it goes away, to bring their hand down. If the patient raises their hand immediately and then brings it down, that's a healthy tooth. If they raise their hand up and they look like they want to punch you and their hand does not go back down, that is a tooth that is possibly dying or in the process of dying. If they do not raise their hand at all, that tooth is now dead and it doesn't have any more feeling in it. So as brutal as this could seem, the cold test, we do really want that patient to raise their hand and put it back down so we know the tooth is healthy. So another option for a diagnostic test is an electric pulp tester. You guys see a picture of it here on the right, and that is going to test the nerve and pulp vitality by giving us a number which correlates to how healthy it could be. And you want to follow the directions of the manufacturer on any electric pulp tester, and of course your doctor will train you on how to use it as well. The bite stick, otherwise known as Tooth Sleuth, which is the name brand. You might not have a tooth sleuth, it might just be a bite stick. But this is going to determine if the tooth is fractured or cracked and just how badly it might be, if we can put a crown on it and save it, or if it does need to be extracted. Let's talk about symptoms of abscessed teeth. So any lingering pain to hot and cold stimulus, pain on biting pressure, spontaneous pain that lasts, or swelling. These are all symptoms that the patient may or may not have. They might have 1 or 2, they might have all of them. These are the symptoms that we're looking for, though, when we see that a patient's tooth is starting to die and turn necrotic, which would in turn need root canal treatment. This is a picture that, I don't know if you guys remember this, but you did see this on week 1. It was a lot, right? So on the left side, you see a normal tooth, your enamel, dentin, pulp, your gingiva, the bone, and of course your root canal and all of that good stuff in the anatomy. The other one is your abscessed tooth. So it's showing you an old amalgam filling. It's a silver filling in there, where the tooth decay started and where it ended up. So it's going down through the dentin layer into the infected pulp chamber, and the path of least resistance from here is going to be the root canal, right? So it's going to go down that root canal all the way to the apex of the tooth, and this one has created a big nasty abscess. Now the patient could come in with that abscess and be really swollen, or again, guys, that could travel up through the periodontal ligament and exit that way into the patient's mouth. However, they do still have some sort of abscess in there. It just might not be huge where it's swollen. A lot of times on the x-ray, you will be able to see it. You see this radiolucency right at the apex. So this is showing us that we, what is this, 13? Tooth number 13 at the apex does have radiolucency, so more than likely it is abscessed and it does need to be root canaled to save that tooth. When you see this on an x-ray, you by no means, under any circumstances, are allowed to tell the patient. You are not the doctor. You are not the provider. Yes, after so many patients, you will be able to see it and go, oh, we're going to have to root canal that tooth. Or, oh, that one's got to go. That one's going to get extracted. But remember, you do not ever give a diagnosis. It is not your job to do so. You are not the dentist. It is going to be up to the doctor to diagnose the tooth and answer any questions that the patient might have. Please keep that in mind, because every single time the patient's going to go, how does it look? How does it look? You take the x-ray, how does it look? And I usually tell them, I got the right tooth, we're good, so I'm going to go get the doc, have them look at it, and we'll be right back. And I exit immediately because they're going to want to ask you more questions because they want you to tell them. And it is not up to us to do that, so please keep that in mind. Endodontic treatment. We're going to talk about several different treatments that an endodontist can do. As far as root canals go, they do other stuff as well. And we will talk a little bit about some of the surgeries that they can do. But the most common thing will be pulp therapy, indirect pulp cap, a direct pulp cap, a pulpotomy, and a pulpectomy. So let's talk a little bit about what each one means. The pulp therapy is going to be root canal therapy. So they're going to go in there, they're going to take out the nerve, artery, and vein, they're going to clean out those canals and widen them, and then they're going to fill them with a substance called gutta percha, which is a rubbery substance that kind of gives your tooth that spring still and acts like a fake nerve, artery, and vein in the tooth. And this is to keep it clean in there so there's no infection, and also to keep the tooth really sturdy as a whole, because once it is no longer living and it's died, it becomes very brittle, and we don't want the tooth to fracture off at the gum line. It is very common for people to get root canals, not come back and get a crown, and for that tooth to fracture off at the gum line, and then we're extracting what's left of the root, and we have very unhappy patients. So it's important that they complete their endodontic treatment, and I would explain that to them, whatever that treatment may be. Sometimes the dentist will say, you know what, all we need is a permanent filling in the access hole. That's it. We're not going to do a crown. Or the majority of the time, they will diagnose a crown because they want to save that tooth. An indirect pulp cap is actually what we would call a liner. I know we talked a little bit about liners when we were reviewing crown and bridge, and they would put an indirect pulp cap on the tooth as sort of a last option, and also as well a direct pulp cap. So direct pulp cap is going to go right on top of that nerve. Indirect is close to it. Maybe we could see a little bit of pink, but we're not on top of the nerve yet. So we're going to put a liner in there that helps create secondary dentin and also releases fluoride to help remineralize the tooth. We're going to say a little prayer, send them on their way, and hope that their tooth gets better. And then we're going to tell that patient, you know, if you have any lingering pain, any lingering hot and cold sensitivity, any spontaneous pain, please call us and let us know so we can reevaluate the tooth. We're going to give it about 2 weeks and see how it goes. Sometimes the tooth will heal and it's okay, and we can get a couple years out of it before we actually have to do root canal treatment. The other one is a pulpotomy. Now, a pulpotomy is a baby root canal, right? That's what we do with children. So we basically take out the nerve, artery, and vein out of the pulp chamber, but we don't go down the canals. And not only that, but it is a baby tooth, so it'll be on its way out soon. But a pulpotomy is for children, and we don't fill the tooth with gutta percha. We usually put a cotton pellet in there and fill it with permanent filling material, whether that be amalgam or composite, and call it a day. A pulpectomy is what we would do for an adult if they were having, let's say, half of the root canal done. So here is an example for you. Patient comes in very, very swollen and a lot of pain, and we are not able to complete that root canal treatment same day. The reason for that is because they are so swollen with infection, we don't want to seal that in, right? That's not a good idea. So what the doctor will do is go in and, again, remove the nerve, artery, and vein that's dead and necrotic, all the dead necrotic tissue and decay. They're going to put some medicament in there, whatever they choose, could be any brand. But basically what it is an antibiotic for the tooth that they're going to push down in there. They're going to put a little cotton pellet on top with a temporary filling. And then we're going to tell them, here's some antibiotics for you to take for 2 weeks. Please come back and we will finish your pulp therapy. We will not charge them for a full root canal because we don't know if they're coming back, right? They might not come back. So this is what we would call a pulpectomy, because the root canal has not been completed yet, but we did at least get them out of pain. They're not in pain anymore, and they're starting to take antibiotics and heal up that infection before we can complete that root canal treatment, which is so important. Okay, rubber dam and endodontics. Those go together like peanut butter and jelly. Guys, these two always, always, always go together. The reason for this is because we don't want our patients to aspirate or swallow any of these small instruments. And I know you guys are really good at placing rubber dams because you've already had your midterm and you rocked it. So just remember, this is the standard of care. We have to have a rubber dam in place if we are doing any sort of endodontic treatment. Have to. Sodium hypochlorite, otherwise known as bleach, right? So this is what the doctor will be using to rinse and disinfect the pulp chamber. So at this point, the patient is seated. We've taken notes. The doctor's done all of their tests, right? Cold test, percussion, pulpation, all that good stuff. And now we've decided, guess what? You need a root canal. So they're going to go ahead and make an access hole on the occlusal of the tooth. And then they are going to start to clean it out with a broach. Once they get the nerve, artery, and vein out, they're going to rinse it out multiple times, not just once, but they're going to use this lovely syringe, this little monojet syringe that you see on the side. Looks like it has a needle on it. It is sharp, but it is not the kind of needle that you would inject someone with. Instead, it's very thin, so it can get down into those pulp canals to rinse out all of the bacteria that's in there. Formocresol is an older medicament. We don't really use it anymore, but it's a very good example of what we sometimes would use to put into the pulp chamber in between that endodontic visit so we can wait for that tooth to heal up. Another instrument we'll be using in endodontics is called an endo ring. It goes on the doctor's ring finger, and it's really nifty because it holds all of the files, and it also has a ruler on there so they can measure the length of the root canal, and then they push down that little yellow piece, this little yellow piece right here. They're going to push that down to where it needs to go, so that way we don't perforate the apex of the tooth. We don't want to go through it. And if it wasn't where it needed to be, we could possibly go through the tooth, and that would be bad, right? We wouldn't want that to happen. That wouldn't be a good standard of care. So what you're seeing here on the endo ring is the endo file, what you see here. And basically, once we have the length of the canal, we're going to push that down to where it needs to stop. And then the doctor will use this little hand file to widen the canals, just like that. They're going to twist it back and forth with their fingers and widen those canals and get it ready for the gutta percha. This instrument is called a broach, and it has tiny little strand of barbed wire on it. It's very different than the handheld files that we saw in the previous picture. So the files are going to widen it, where the broach has barbed wire so it can get in there, grab that nerve, artery, and vein, and pull it out of the tooth. So they're used for removing nerve tissue from the canal. Their barb-like hooks quickly snag tissue within the canal so it can be removed in one piece. So a lot of times we can pull it out, and the abscess will even be at the bottom of that apex of the nerve. So we can just take it all out at once, and then they'll probably rinse it out real good, and then they will start to widen it with these files. In this picture, you can see the difference between the broach and the file. Files are color-coded and numbered instruments which clean the canals by scraping the sides in an up and down motion. As the numbers increase, the files become thicker. This is the one time in dentistry I need you to pay attention to not only the number, but the color. This is the one time that color matters, where previously it's like, okay, the yellow long needle. Well, you could get a short yellow needle or a PDL yellow needle, so don't get hung up on colors. This is the one time you need to follow the color and the number because it will coincide with every other step in endodontics, which we will get to. So these hand files are what they use by hand to widen the canals of the tooth and get it ready for the gutta percha. If they don't want to use a hand file, there is a nifty endodontic handpiece that they can use that they use these lovely rotary files in. So there's a series of sizes, just, same thing as the other ones. And it's going to do the exact same thing. It is going to widen and shape the canal and get it ready for the gutta percha. So this one would just be a motorized handpiece as opposed to doing it with your fingers. The other option, which isn't always used, it's not commonly used in every root canal, but is a drill or reamer. The reason that the doctor would need to use this is, let's say the patient had a root canal, and for some reason, 20 years goes by and it's hurting again. It is now reinfected and there is recurrent decay underneath the filling or the crown or whatever the case may be. The doctor is going to need that drill or reamer to get that calcified gutta percha out of those canals so we can widen them and refill them back up with a new gutta percha and make sure that we get out any dead necrotic tissue or any decayed enamel and dentin layer of the tooth. So this is the reason why we would use a drill or a reamer. It's not something that we would use every day for a root canal. Okay, so the patients come in and we have taken out the nerve, artery, and vein. We have rinsed it, and we've also gone through and widened it with our hand files. Now we need to dry it. We have to go in there and make sure everything is nice and dry and there's no blood, no saliva, no water, no bleach, nothing in there. We want it nice and dry. So we're going to be using paper points. Paper points are similar in size to the files, and they're absorbent little paper wicks that are going to be used to dry the canal. So remember when I told you keep track of that color and number? So let's say we ended on a red 25. Then you're going to find the red 25 paper point and hand them to your doctor so they can dry it out. And it will take as many as we need. You might need to use 2 packages, you might just need 1. And we will continue to dip the paper points in until they come out completely clean and completely dry. Once it is dry, then we will go in and fill it with the gutta percha. This is more of an old school way to do it, what you see here. There are these nifty little guns now that have liquid gutta percha and it just whoop, fills it right up, call it a day, super easy. But we are going to go through this way because a lot of dentists still use it and it's not a bad way to do it, it just takes a little bit longer. So again, if we ended on red 25, there it is on the bottom, on the left. We're going to grab that red 25 gutta percha and we are going to use as many as it takes to go ahead and fill that canal and complete the root canal. Before the doctor pushes all of the gutta percha into the canal, they're going to dip it in a pulp canal sealer cement, and that is going to seal up all those little spaces and voids, because if you think about it, all those little points aren't really going to touch and connect each other. So the best way to do it is to dip the gutta percha into the pulp canal sealer cement and then go ahead and put it in that way. Again, another reason why they like the liquid, because they don't have to use this, because then there's not an issue with voids anywhere. Once we have all of the gutta percha in the tooth, we are going to use a butane torch to heat up one of our instruments and cut off that excess gutta percha. And I have a picture coming up that will show you what I'm talking about, because I know it's kind of hard to envision. Let's see. The last step that we'll be doing once we cut off the tips of the gutta percha is putting a temporary filling in, because after this root canal, they're going to go back to the general dentist and get their crown done. So we don't want to put a permanent filling in that they're going to have to remove. We want something easy for them to remove. Not only that, but let's say we couldn't finish the root canal today and we want them to come back and finish it later because we had some medicament in there that was just going to help heal the tooth. All right, let's talk about instruments. So we went over all of the materials just now. Let's talk about instruments. So you have an Endo Explorer, very different than the Explorer that you've been looking at in general dentistry. It kind of has a shepherd's hook on it. The Endo Explorer is still very sharp like the other one. So the Endodontic Explorer is longer and straighter than a regular exam Explorer. It should not be confused with the spreader. The spreader is the one below it, and the spreader is a pointed instrument used to squeeze the gutta percha point sideways against the canal wall as it is pressed in. When removed, a fine gutta percha is inserted and the process is repeated until the tooth is filled. So what you're looking at here is looks like tooth number 9, and they are pushing all of the pieces of the gutta percha into the lingual side, and they're using that instrument to measure it and push all of the gutta percha in with the spreader bar to make sure that we completely fill the tooth. The next instrument is your endo plugger. It has a blunt edge on it. Do you see that flat end? So the endo plugger is a flat-ended instrument similar to an amalgam plugger, but it's smaller. It is used to pack the gutta percha in an apical direction. The plugger can be heated with a butane torch to melt off the excess gutta percha sticking out of the tooth and fuse all of them into one solid mass. So we would warm it up and then cut off the excess gutta percha. In this picture, you can see we're removing the gutta percha, so that way it's only, it stops exactly at the root canal, and then we're going to fill up that pulp chamber with a temporary filling material. So the picture that you're looking at on the right is actually a bird's eye view. So we're looking down into the tooth. That is enamel on the outside, and then those 3 points are where the canals are, and they are filled with the gutta percha, and the plugger was used to condense it down into that tooth. Your other instrument is going to be the locking pliers. They're going to be used to hold the gutta percha and paper points, anything small like that. It's going to lock down on it to help you not drop it. Another one is the endo spoon excavator. It's similar to spoons in restorative instruments, except that it's longer to reach deep into the tooth and the pulp chamber. Here is also a picture of an old school measuring ruler. Now that we have those endo rings with the ruler on them, we don't use these as often. And of course, it gives you an example of the file here where we would move the stopper once we measure it to make sure that it's the correct size. This is an alternative to measurement x-rays. So before they had a root ZX system to measure the canal of the tooth, we used to have to take x-rays and measure it using the system that we had, whether it was Kodak or Dexis or whatever the system might be. And that made it pretty difficult because that means your x-ray had to be right on. So your bisection of that PA better be perfect. There cannot be any elongated or foreshortened roots on there, or we're not going to get what we need, right? So the cool thing about this is the top one you see has the endodontic handpiece on there, and then the bottom one shows just a little hook, and that one will hook onto the handheld files, so we can use either one, whichever one your doctor likes to use, and we can still go ahead and measure that apex down, which really comes in handy. The endo tub and tray setup is going to be pretty big. So you're going to add this to what you already have going. You're going to be adding this to your restorative treatment. So you have all of your restorative instruments plus your endo tub and tray. Post-op x-rays of endodontic treatment. So what you see here is a posterior and anterior root canal. You can see where the space is and where we have our temporary filling. So we know that we didn't do a buildup or crown or prep for anything like that. That will be all up to the general dentist. So what you see here is a completed root canal treatment on an x-ray, and that is your lovely bright orange gutta percha sticking out at you. That's very radiopaque and shows you exactly what was filled all the way to the apex of the tooth, and they look great. The endodontic surgery. Endodontists can do several different types of surgery to help a patient that needs root canal treatment, depending on the type of treatment that they need. So an apicoectomy is the surgical removal of the apical portion of the root. So what they would do is, let's say the patient had really severe trauma to the tooth and it got pushed up into the alveolar ridge bone, and that's why they needed a root canal, because of the trauma. Well, let's say we did it, but it's still hurting. The doctor might go in and do what's called an apicoectomy and flap that tissue back and remove the apical portion of the root. There's also a retrograde restoration, which is a root end filling needed when the apical seal is not completed. So previously, in the previous slide, you guys saw that the root canal went all the way to the apex of those teeth. It was done beautifully. It was gorgeous. They did a great job. Let's say they didn't get that far and they didn't have a root ZX system to measure, so they don't know how far exactly to go down. So the small preparation is made at the apex and it's sealed with gutta percha, amalgam, or composite. So that is also another option. And then the third one is root amputation, which is removal of one or more roots of a multi-rooted tooth without removing the crown, which is really important. So remember, you know, after we've had this endodontic treatment and we've had root canal done, we are putting a brand new crown on. And let's say one of the roots is still infected and it's just causing issues. The doctor has an option to flap that tissue back, go in and amputate that root if that is the best prognosis for that tooth in that patient. This is a summary of one visit endo treatment. I want you guys to know this very well. So if you have a chance to go through and read through all of it, it basically goes through everything we just talked about, which would be one visit to endo. So that's why it's so important that you guys know all the steps, because we want you to know the sequencing and how to set up for it. If you're not sure, I would take notes, put it in a little tiny notebook that you can keep in your lab coat, so that way you know what to do. So if your doctor is doing a root canal that day, I would take notes on everything they do, what type of materials that they like and use, and make sure you write it all down because it is a very long visit. Once the root canal treatment is done, again, the final visit is going to be a buildup in crown needed to finalize the root canal treatment procedure to protect the tooth from fracture. This is done with the general dentist. So once they're done with us, we give them a temporary filling and send them on their way back to the general dentist. And we want you to remember every tooth that has a root canal treatment will need a crown. So unless the doctor really feels like that tooth won't be brittle and susceptible to fracture, they might put a filling in, but the majority of the time they are going to crown it because that is now the standard of care for root canal teeth. That's what the American Dental Association is telling us we need to do. Although not every tooth has a crown, will need root canal. So I don't want you to think, oh, this patient needs a crown, we have to do root canal. That's not the case. It's every time we do a root canal, we really need to be putting a crown on that tooth to save it and keep it healthy. And also, you know, to make sure it's not going to break off. All right, let's talk about periodontics. Woo! Who wants to learn about periodontics? Okay, so the periodontist is a dental specialty involved with diagnosis and treatment of diseases of the supporting tissue. The periodontist is a dentist with advanced knowledge in this specialty. So this is hygiene, right, guys? So we're just talking about your gingiva and your at-home hygiene and how it's affecting you in your daily life and all of your supporting tissue. So the stages of hygiene are adult prophy, which everyone should be getting an adult prophy at a minimum 1 a year. But usually the American Dental Association is asking for every 6 months for you to stay healthy and not end up with gingivitis and possibly periodontal disease. So every 6 months or possibly more, depending on the health of your gums. Full mouth debridement is also another stage of hygiene, and root scaling and planing is what we would call SRP, which is also what we refer to patients as a deep cleaning. A lot of times we numb the patients when we're doing that sort of cleaning. Adult prophy, removal of calculus and plaque and coronal polishing. Only dentists or hygienists will be performing scaling. So remember, you guys are allowed to coronal polish. You are not ever allowed to remove calculus and plaque with a scaler. Only hygienists or dentists are allowed to do that because they are trained professionals and they do carry a license to do that in the state of Colorado. So please keep that in mind. When we're talking about full mouth debridement, we're talking about removal of heavy calculus buildup. I'm sure some of you that are starting to follow the dental blogs online or Instagram have seen some of those pictures of the lingual lowers where they have really heavy calculus buildup. We want to remove all that calculus and reduce the bacteria within the pocket because more than likely they have something higher than a 2 or 3. It could be a 4 all the way to a 9, maybe even deeper than that. So this will help return tissue to a healthy state and reduce bleeding and swelling of tissue. So full mouth debridement is exactly what it says. When we need to debride and remove all of that calculus out of the mouth and then get them back into possibly perio maintenance, which is every 3 months, and then hopefully back to just an adult prophy. Really depends on that patient's home care and, you know, how quickly we can move forward with the health of their gingiva. Root scaling and planing. This is what we call a deep cleaning. So it requires 2 or more appointments, and the patient will be numb. They have to be numb for this because we are going subgingival. So the hygienist is going to use scalers and curettes, or possibly the periodontist if we end up referring to them. And they're going to go deep below the gingiva and remove buildup from the root surface and any diseased tissue from all of those smooth surfaces. So if they have to, they're going to use a curette to remove that dead necrotic tissue because we want all of that bacteria out of the mouth so the mouth can start to heal. The patient will be required to have maintenance follow-up appointments, which means perio maintenance every 3 months. They don't have to have a doctor visit every time they go in to do the perio maintenance, but it is important that they come in and follow up with the hygienist and keep those cleanings on track. Referral to the periodontist. The general dentist or hygienist can refer a patient to a periodontal office. Treatment will be completed, and then the patient will return back to hygiene or general dentist for periodontal maintenance. Now, depending on what the periodontist finds, we will talk about different types of treatment that the periodontist can complete with the patient. Periodontal disease starts with plaque and calculus accumulation around the teeth, and normally this is removed during the visit with the hygienist. But if the patient hasn't been in to see a hygienist in, you know, more than a year, 2 years or longer, let's say they were on deployment, right? And they weren't able to go in to see the hygienist, but they're brushing and flossing like they're supposed to, they still get buildup that the toothbrush and the floss aren't able to reach. So a lot of times those patients will come in and we'll do a full mouth debridement on them. Their mouths heal up and they're right back into having an adult prophy back to normal. So it just really depends on how quickly they heal. The determining diagnosis. So any determining diagnosis for periodontal disease is going to include all of these different tests that we have to do while they're in the chair. So the hygienist will do perio charting, and part of the periodontal charting, they are reading pockets. So they want to see how deep the pocket is. A healthy pocket should only be to 3 millimeters deep. Anything past 3 millimeters deep could be swelling, it could be gingivitis, or it could be periodontal disease. They're also going to be determining the furcation of the tooth mobility, if there's any peritulence, recession, and of course bleeding. And all of those notes will go into the chart. If the pocket is if we allow to remain a pocket, it develops between the tooth and the gum tissue. The hygienist or the dentist can measure this pocket depth with a perio probe. The perio probe is the instrument on the other side of your shepherd's hook Explorer that you guys have been seeing. And this picture is showing you a pocket depth of 5 millimeters. So that tooth has a pretty deep pocket in there. This is showing you a picture of some gingiva that's very irritated, very red, and it looks like when they are probing, there is bleeding upon probing, which you can see in a couple other areas that there's some blood as well. So anytime we see that, that is a sign of periodontal disease because the tissue is bleeding, more than likely because it is infected and it does have periodontal disease. So tissue infection and destruction continues down the root. Here you see on the right side of this tooth, the disease has begun to destroy the bone support for the tooth. So that is what will begin to happen when you have periodontal disease, is not only will you get recession on your gum line, but your bone is also receding because of that bacteria. That is when the teeth will usually become mobile and we will need to do extractions and start talking about alternate options as far as possible dentures, maybe implants. If we can get rid of the bacteria, they might be a good candidate for an implant. That would be up to the doctor to decide. Another common instrument used in perio are your scalers, your curettes, surgical knives, and of course the ultrasonic scaler is very common in perio. The ultrasonic scaler is going to provide rapid calculus removal. It will reduce hand fatigue of the dentist or hygienist, converts very high frequency sound waves into mechanical energy in vibrating forms, and it's going to spray water. So the water is going to cool off the tooth as well as flush out any debris or bacteria from the pocket, which is awesome, right? We want to get all of that bacteria out of the pocket. This is not to be used on children. Anytime they use these, it is removing a little bit of the enamel of the tooth. So it's important, again, that only a dentist or hygienist use these instruments because they are licensed to. Okay, so let's talk a little bit about periodontal surgery. When non-surgical treatment is ineffective in stopping the disease, periodontal surgery is needed. So the doctor will gain access to root surfaces by lifting the gingival tissue. Sometimes the doctor will have to lift the gingival tissue to go ahead and remove calculus from the root surface of the tooth that we can't get to without doing this type of surgery. A gingivectomy is removal of diseased tissue. So to reduce the depth of the periodontal pocket, like we were talking about with a 5 millimeter, they can use a laser, or they could possibly go in with a surgical knife, which is a scalpel, and remove that tissue that is necrotic and causing problems and bacteria. So this picture is showing you before and after. They also might do a gingivoplasty or a gingivectomy for a patient who, let's say they just have really large gums and they're covering their teeth, but there is no periodontal disease. It could be a cosmetic reason as well. So this is showing you a cosmetic reason to add tissue. So you can see the before picture, they have really bad recession, and it could be from clenching or grinding that causes recession. It could be from toothbrush abrasion. It could be hereditary. So this surgery is involved in reshaping or contouring the tissue. So they're going to take a skin graft and go ahead and reshape and contour the gingiva. And you can see the gorgeous after picture. It's like, wow, looks amazing. They're very talented. Very, very talented indeed. Crown lengthening. This is amazing. So remember we talked about root canal treatment and how if we don't put a crown on the tooth, it could break off at the gum line, and then we're left with this root structure, right? That now, what are we going to do? How are we going to restore this tooth? Well, this is an option to continue to restore this tooth and not have to just simply extract the root and call it a day. So it is a surgical procedure that your periodontist can do, and it's designed to expose more tooth structure for the placement of a restoration. So what they're going to do is flap that tissue back. They're going to remove part of the alveolar ridge bone all the way down as far as they can and expose the rest of the enamel of that tooth, which was below the gum line. And then once it heals, we will prep that tooth and put a buildup on it and go ahead and put a crown on it and save it. And that's it for perio for now. All right, oral and maxillofacial surgery. I know you guys have been waiting for this. This is one of the most exciting things that we do in dentistry. All right, let's talk about wisdom teeth. Who all have had their wisdom teeth removed? I'm sure you guys have some great stories about what you experienced when you had your wisdom teeth removed. The consequences of not removing impacted third molars sometimes can be cyst formation. This one is very big, and I know it's kind of an exaggeration, but it's real. So you can see the arrows pointing to just how big this cyst has gotten, and it could result in, you know, a lot of bone is missing right there where that infection is, and it could result in a broken jaw. It could result in losing more teeth. It's just never good to let these kind of things go and not get it taken care of. So if your dentist has diagnosed your thirds and explained to you that you do need to have them extracted, I would get it done as soon as you can, so that way you don't end up with a giant cyst or possibly other issues. So let's talk about the other issues that it can cause. So chronic infection from a partly erupted third molar due to food and bacteria becoming trapped under the flap of tissue. That's very common because it's trying to erupt. Maybe it doesn't have enough room, so now it's butting up against the most posterior second molar, and it is causing decay on that one. Not only that, but it's also getting bacteria and food stuck underneath that flap of gingiva there that we can't get rid of because the tooth isn't able to completely erupt like it's supposed to. Crowding of anterior teeth due to pressure. A lot of dentists agree and disagree about this, but it is something that has happened because of a third molar. Let's say you already had your ortho done and you had your braces off, and now here come your third molars in to put everyone out of whack. Cyst formation around the totally impacted third molar, that can happen because of the bacteria that gets in underneath the tooth because it is barely starting to erupt and we're just not able to keep that clean. And then, of course, the decay of the second molar root due to food and bacteria entrapment again. So if it's butting up against the second molar and causes a very big carie or cavity in the root, that tooth will be lost more than likely. I have seen this happen, actually, in a girl who was 16. She had her wisdom tooth for a while, and it was butting up against that second molar, caused decay, and she ended up losing both of them, and also the upper, because it started to super erupt and it wasn't able to stay in its place. So space in the mouth is bad. Try to remember that. We don't ever want to lose teeth. We want to keep them. Your third molars, however, are usually in a significant area that isn't affecting any opposing teeth. So when we remove those, it's kind of like they were never really there. All right, let's talk about oral surgery instruments. You have two instruments on this page that are periosteal elevators. One of them is a Woodson because it's smaller, and the other one is the periosteal elevator. The periosteal elevators have a spoon shape on one end and a narrow or sharp point on the other end. They're used to elevate the gingiva away from the bone after the initial incision. Some doctors don't do incisions for all of their extractions, so I don't want you to get it in your mind that every time we do an extraction, we're going to bust the scalpel out and start cutting open gingiva. Not all doctors do it that way. Some of them will simply use the periosteal elevator to begin loosening the tooth and luxating it out of the socket. Another instrument that we use in oral surgery are tissue retractors. You have two different types of tissue retractors in this picture. The Minnesota retractor is on top, and the Selden retractor is on the bottom. The most commonly used is going to be the Minnesota retractor, and they're used to hold back the cheek and gingival tissue from the operating field for better visibility. So we could be holding back part of the gingiva that they've flapped open, possibly their cheek, their tongue, wherever we need to get in there and hold down that tissue so the doctor can have better visibility. It's very important. Elevators. So we have two sizes of elevators here that are most commonly used. If you were to look in a Henry Schein book or any dental supplier, you would see hundreds of types of elevators, but we're going to teach you the most common in this class that you'll see. So the straight elevators resemble screwdrivers. The larger numbers have smaller tips. You need to remember that because you will need to know which one is a 301 and which one is a 34. So 301 is on top, bigger number, smaller tip. 34 is on the bottom picture, and it has a smaller number with a bigger tip. This is used to luxate and loosen the tooth out of the socket. It's going to elevate it in there. All right, crier elevators, not a great name. It's not usually the name we choose when we talk about it in front of the patient. The doctor will usually ask you for what's called an east and west elevator. Why they have two names? Maybe somebody just didn't like the crier name. I mean, I personally would not want to hear that if I was in the chair. So I want you to know that these are not only called crier elevators, but they're also called east and west elevators. And they are usually used to try to elevate out any buried root tips. And you can see there's two different types of handles in these pictures. We have the T-bar and then, of course, the screwdriver handle. Okay, so the tooth is loosened in the socket and it's ready to be extracted. We are now going to go forward with our forceps, and we're going to show you three of the most common forceps used. Again, there's like so many different ones that we could choose from, but these are the most common. So identifying the number of the forceps, and it appears on the handle, so it's already cheating for you. It's going to tell you the number on the handle. Now, you'll need to remember which one is for maxillary and which one is for mandibular. And the way you can remember that is the way that the curve of the handle is, that goes in your palm. So if you look at this, the 150 is a maxillary forceps, and the curve of that handle goes in your palm and it's facing up. The 151, when you grab it, is facing down. So the 151 is a mandibular forceps, and the 150 is a maxillary forceps. You need to remember that because it will be on your final exam. Not only that, but it will be something you do at least once a month, maybe twice, maybe 3 times. Maybe your doctor really likes to do extractions and you do it every day. So you need to remember the name of the forceps. It's not just 150. It is a 150 maxillary forceps. The 23 forceps are also called cow horns because of their shape. And they're mainly used for lower molars, but to be honest, the doctor's going to use them for whatever they want, right? You're not going to be like, oh, we're not working on the lower, so you can't have the cow horn. Don't ever make that decision for your doctor. A lot of times when we're doing oral surgery, I like to get these out, or the deep grip ones out, and keep them in the back, even though they're not opened, and only open them if I need them. This is giving you an example of the difference between a 150 maxillary forceps and a pedo 150S maxillary forceps. So again, you see the curvature of the handle goes in the palm and the forceps is pointing up. So that is one way to tell that it is for maxillary placement. We also have root picks in here. The root pick is characterized by its slender pointed tip. Sometimes they'll call them root tip picks. These instruments are used to loosen and remove broken roots deep within the socket. A lot of times it'll be a double-ended instrument as opposed to 2 screwdriver handles. And we also have a special section for surgery. This is called a surgical section. You can either have one that needs to be sterilized again and reused, or it is disposable. Suturing instruments. Sometimes the doctor will need to suture the patient back up if we had to make an incision, and these are called Dean scissors. They're very long, so they can reach to the back of the mouth and cut those sutures. We also have needle holders, which are a very long hemostat. The needle holders are what the doctor is going to use to suture the patient back up. Here's an example of the needle holders clamped down onto the needle for the sutures. Depending on what your doctor likes, they'll tell you which suture they need. Here's our scalpels. Remember, guys, we are not going to use that word in front of patients because it's terrifying when you're sitting in the chair, right? So it will be referred to more than likely as a 12 or a 15. They might not call it a Bard Parker. They might just say, can you hand me the 12? Now, obviously, you're not just going to hand them a blade, right? It's going to be attached to the Bard Parker. So depending on which one they need, they will let you know and ask you for it specifically. Okay, let's check out this lovely surgery that we have pictures of for you guys to see, so you can see exactly what it looks like. Okay, sorry, I went ahead too quickly. Going back. Okay, so this is an impacted picture of number 32 on the lower right, and it is termed horizontal impaction. The incision is made distal to the number 32, which is protruding slightly through the gum tissue and the arrow. So they made an incision back here, and now they are going to extract tooth number 32, which you can just see the cusp of it kind of running into 31 there. The incision is extended to the facial of 30, and you're going to note this is a 15 blade because it's straight. The 15 is straight and the 12 is curved. The third molar is fully visible now, and the instrument on your left is a Minnesota retractor, and the narrow instrument on the right is a surgical suction tip held by the assistant. This is the only time in your career we will be telling you to put the suction exactly in the way of the doctor. Because there will be blood. This is a very clean photo, but there will be blood on the tooth and in the area, and the doctor can't see with all that hemo everywhere. So you will be pushing your suction all around that area, in the socket, everywhere, once the tooth comes out. because you want to get all that blood out of the way. We don't want the patient swallowing all that blood. It can make them sick, make them have a stomach ache. And we also want a good, clean, visible field for our doctor to work in. So what you see here is the periosteal elevator, Minnesota retractor, and the suction. And this is the jawbone right here, guys. So that's the impacted third molar. The crown portion of the tooth is next cut off using a handpiece to facilitate removal of the roots. The assistant uses the retractors and the suction tip to hold the tongue back and keep the area dry. So you can see we have retraction, and then we also have a suction right in the middle of it on top of the tooth, while the doctor comes in with the handpiece and separates the crown from the roots. The crown is cut loose from the root of the tooth. The 301 straight elevator loosens the crown from the root. So it's going to luxate it up. A lot of times once it's loose, you can just grab it with your suction and pull it out. Because the double root cannot make the turn to come out, the mesial and distal root are separated using a handpiece. The distal root on top is then removed using a straight elevator as shown below. So now they're pulling that distal root out first, and then the mesial comes out next. A lot of times at that point, the doctor will go in with sterile water and irrigate out the tissue. If they need to, they might need to use a curette and take out any dead necrotic tissue that might be in the socket, and then we'll irrigate it again before we suture up the flap. And this is it. You're going to be giving post-op instructions for that patient. A lot of times we will be giving them sterile gauze to take home. We usually ask them to, you know, if they have severe bleeding, to wet the gauze first before they bite down on it, because we don't want it to pull out any clots. In this instance, they've been sutured up, so we really shouldn't have any dry socket issues. But if we didn't have to make an incision and we were just pulling the tooth out, we don't generally, there's nothing to suture up at that point. So we would have an open socket. So we would really want it to stop bleeding and start to clot over it and heal. So in that instance, you would really want the patient to wet the 2x2 before placing it in the mouth to bite on. We are only using it as compression. It's not there to soak up a bunch of blood. Now, granted, that's what it's going to do, but that is not the purpose. The purpose of the 2x2 in the mouth is to be a compression to start that healing of the tooth and to stop the bleeding. So, little misconception on what we're doing with the gauze in the mouth. So make sure you explain that to the patient. All right, let's talk more about oral surgery. So we did our thirds. Now, what else can they do, right? What else does oral surgery like to do? Malocclusion, so maxillary and mandibular jaws, they fail to grow properly. If it cannot be fixed with orthodontics, an oral surgeon is required to remove parts of the maxillary and mandibular jaw into a balanced and functional position. So that is one thing they can do. Their TMJ surgery, a lot of times they'll be working on the temporal mandibular joint, trying to get in there and fix whatever tendons or popping or issues that they might have. Any facial repair or facial infections like canine space infection, mandibular infection, cleft lips, sleeping disorders like sleep apnea, removal of soft tissue of the oral pharynx. Sorry guys, it's such a hard word. Your oral surgeons can do that as well. Osteosurgery is one of the most common that we see in the dental office, which is involved in bone modification, shaping, or removing or contouring. So any osteoplasty, bone is contoured and reshaped. Osteoectomy, bone is removed. So this could be tori that they have in the mouth that they need removed. It can be completed by a periodontist as well. Just so you know, osteosurgery could be done by either specialty perio or oral surgery. But if, let's say, a patient is getting a denture and they have a really big alveolar ridge, and we know the denture can't fit up and over it to get that good suction on the maxillary, they might need to flap the tissue back and go in there and do a little bit of an osteoplasty and recontour and reshape that bone and get it ready for the denture. They also do biopsies, removal of abnormal growth from the oral cavity, send it to a lab to determine whether or not it is cancerous, so biopsies are important. Okay, so let's talk a little bit more about post-op instructions after the doctor has finished any of these surgeries that we just talked about. So ice packs are sometimes given to patients in the office following extraction of the procedures. The extra 2x2 sterile gauze can be given to the patient in order to change the dressing at the extraction site. The gauze is folded over and biting pressure holds it in place at the extraction site. Post-op instructions. Bleeding. Normal oozing may occur for up to 24 hours or more following surgery and is controlled by firm biting pressure on several gauze pads placed over the tooth socket. Keep gauze packs in mouth until you eat. Replace them after eating and keep them in until bedtime. If bleeding is brisk and fills the mouth quickly, call the telephone number listed below immediately. So again, we were talking about that. It's really important they know to wet those 2x2s before they put it on the area to bite down. The next thing we're going to go over is swelling, pain. You need to take your pain pills. A lot of times, whoever is driving them home, if they've had some sort of IV sedation, they will have already filled their prescription while they were waiting, so they're ready to go. Muscle soreness is common. It's important that they don't spit or suck while they're waiting for this to heal. So no straws, no spitting. You need to brush and floss like normal. Just avoid that area getting too close to the socket. You don't want to push those bristles down into the socket because that would really hurt. But it is important that they keep up with their oral hygiene so that way we can keep the mouth clean and we don't have any issues. The diet is important as well. We do want them to drink plenty of fluids and to eat healthy. So anything soft, nothing crunchy, sticky, hard, chewy, nothing gritty, like no seeds, nuts, rice, nothing like that that can get stuck into the socket or possibly past those sutures. If infection happens, again, you want to call that number immediately or possibly go into the urgent care. And tea bags. I don't know if you guys realize this, but tea bags are useful to control bleeding at home. So if bleeding seems to be excessive at home tonight, wet a tea bag with warm water and place it over the bleeding area. Bite down firmly for 1 or 2 hours and bleeding should stop. It's going to act as a vasoconstrictor and stop the bleeding around that area. And then this just again reminds you not to eat anything crunchy or hard until the site starts to heal. The periodontist versus the oral surgeon. So a couple times I mentioned, and the periodontist can do this as well. So both specialists perform many of the same tasks, where the periodontist studies longer and takes more classes studying the tissue, and the oral surgeons study and take more classes on head and neck reconstruction. So, but they can do a lot of the same procedures. Implants are one of them. Implants can be placed by a periodontist or an oral surgeon. Just depends on where you go. So it can be used to attach artificial teeth to anchors that have been embedded into the bone, and it is a 3 to 9 month process, and it can be placed by the periodontist, oral surgeon, or prosthodontist. Implants are amazing. If you've ever seen one, you wouldn't even know that it was an implant. But they can replace 1 or more teeth. So we can do a single, we could do a bridge, we could do an implant retained denture. It just really depends. And it really helps prevent bone loss. Remember we talked about space not being good in the mouth. We don't ever want to lose a tooth and not replace it with either an implant or a partial or a denture or something, because once we have bone loss, we have movement. And once we get movement, we usually lose more teeth. And we don't want that. We want to save teeth. This is going to enhance the patient's confidence because it's permanent. It's a permanent restoration. You don't have to take it in and out when you go to eat. You don't have to take it out at night before you go to sleep. You don't have to worry about it, really. You just need to keep it clean like your regular teeth, and it'll function properly. So diagnostics. A psychological evaluation, which is a consult with the doctor to determine if the patient has realistic expectations, a great attitude, and the ability to cooperate during treatment. We're going to do a dental exam. We're going to do medical history and diagnostic cast, which is a picture that you see here of a surgical stent, which is showing exactly where to place the implant in reference to mesial and distal surfaces of the opposing teeth. So it's really important that the patient knows what they're getting into. This is going to be a long process. It is going to take a while to heal, and everyone heals differently. So it might take more than 4 months, or it might take less, or whatever the case may be. And we don't know if the body is going to reject it or not. So that is a possibility, and the patient does need to be aware of that happening. Implant contradiction, financial, they're not cheap, right? Implants are not cheap. It can be pretty expensive, so it's important that we review that with the patient. It can take many months. And of course, like I told you, possible failure. All of the implants that we're placing are endosteel. So osseous integrated implants are most common form of implant placed. There aren't many out there that aren't going to be endosteel because this is the least likely to be rejected by the body. Surgically placed implant goes into the jawbone, and it is made of titanium because of its compatibility with bone and oral tissues. It goes through a process called osseous integration. So this is the process by which the living cells of the jawbone naturally grow around the implant. So it's going to grow around the implant, lock it in tight like it would its normal tooth, and accept that implant into the jaw. Let's talk about the phases. So first surgery is the implant placement into the jawbone. And then we're going to suture them up and let them heal for months. Could be 4 or 5 months, could be less. The second surgery, the tissue is going to be uncovered and the cover screw is connected to the implant to help shape the tissue for final impression. So we're going to put a custom abutment in there. We're going to take an impression of it and send it off to the lab, and it's going to take a month. Usually it takes like 2 weeks to get a crown. In this scenario, it is going to take a month for them to make a customized abutment and implant crown. The third is the restorative treatment done by the general dentist. So that is when we get the case back from the lab and we seat that custom abutment and implant. And then we usually want to see them back in a month to make sure that the occlusion is still correct and they're doing well, and take another x-ray. We'll get a PA of it to make sure that it is doing everything it needs to and functioning properly. Okay, let's talk about orthodontics. Orthodontics is going to help correct any sort of crowding or crossbite, or what we like to call malocclusion. The definition: the specialized branch of dentistry that diagnoses, prevents, and treats dental and facial irregularities. So we're going to straighten the teeth, we're going to correct crowding or space teeth, correct bite problems, and align maxillary and mandibular jaws. It's very important because not only are we making it look nice and pretty and it's aesthetically pleasing, but now this patient will more than likely stay out of the dental chair because their teeth are aligned correctly. They're not going to have temporal and mandibular joint issues causing popping and pain. They're not going to get headaches. They're not going to get cavities because their teeth are easier to keep clean. They're not going to need any sort of crowns because of clenching and grinding from fracturing teeth. Because once the malocclusion is corrected, things work the way they're supposed to, and we have less likelihood of them having issues and being in the dental chair. So what are some of the benefits other than that? Emotions, right? People will come to us and they are just floored by how happy they are, that they smile more in pictures, it's the holidays, or I'm going for an interview, whatever the case may be. This affects people so much, you guys. And it is so fulfilling to be a part of that with a patient, to see them come out and be so happy with everything you helped, even though it was kind of brutal going through it, right? It's never that fun. It's kind of painful, and, it's a process. But at the end of it, they have better speech, better chewing, no more issues with their joints, and no dental diseases, which is periodontal disease. They're less likely to have periodontal disease if their teeth are not in a malocclusion and they are aligned correctly, because they're able to keep them clean easier. That means they'll floss, right? Because it won't take as much time. All right, malocclusion. Why do we have malocclusion? A lot of times hereditary. Your facial contour, size of your teeth, size of your jaw. It's a lot of times it just really depends on your genes, and it's hereditary. It could be developmental, where you're missing teeth, again, hereditary. Too many teeth, let's say you have a supernumerary, which is an extra tooth, past 32 teeth. And environmental could be trauma, could be habits like thumb sucking, bottles. You know, you see like a 1-year-old with a bottle, or even older than that. All of those really bad habits are going to cause trauma to the teeth and prevent them from erupting properly. Classification of occlusion. We did talk about this in week 1, and this is your chance to memorize it and learn it now. You do need to know this. This is very important for general and, of course, orthodontics. But the orthodontist, as well as the dentist in general, classify the occlusion into 3 categories. So we have class 1, class 2, class 3. The name is neutral occlusion, mesial occlusion, and distal occlusion. And you can tell just by looking where the jaws are, whether it's mesial or distal to the body. And we try not to say buck teeth because it's insulting. So I would just explain to them that they have an overbite or an underbite if you're trying to explain it to your patient. This is showing you orthodontic brackets and instruments, or sorry, not instruments, but materials. So we have all of the hardware. We have the brackets, the wire, the spring, the bands. All of those things come together and help form and push and pull on the teeth to get them into the correct position. So as a dental assistant in general dentistry, you probably, if you work in an office that has ortho, you'll more than likely be placing some sort of seps, which are called separators. We call them seps for short. But it is a separator, which is a small band used to place between the tight interproximal area to allow room for the band to fit. So usually the day before they go in to get their ortho, we're going to have them come in and we're going to place seps in between their teeth. So that big metal band can fit around that molar, and we're not just pushing it into that interproximal space, and there's not any space, right? So we want to make some space. This is probably one of the most painful parts of ortho. Be very honest with your patient, especially the little ones, okay? Because the parents are going to be like, you're fine. I'm sorry, but unless you've had this done, you have no idea how bad it hurts. So let them know this can be pretty painful. You know, this is the only time we're going to ask you to not floss here. It's only going to stay in until tomorrow. Make sure you brush like normal, floss all of your other teeth like normal, and then the next day they'll take it out and put the brackets and the bands and arch wire and all that good stuff on. A lot of times we suggest giving them ibuprofen or something because it is going to be pretty bad, and they're probably not going to want to eat that night unless it's something soft. So make sure you give good post-op instructions, and if you're not sure, ask your doctor. Orthodontics. So a series of adjustments are going to be made throughout the treatment. It could take 6 months, it could take a year and a half. It really just depends on the patient's treatment. Great oral hygiene is very important, guys. If we want this to be successful, they need to have really good oral hygiene. Once the treatment is completed, we usually give them a retainer to keep everything in check and avoid it from moving around in the future. It could be a lingual retainer that's permanent. A lot of people have seen those in x-rays. Polys are the old school wire ones. And then, of course, something removable that's clear, kind of like a night guard. All right, last specialty. I know you're excited. Pediatric dentistry. Pediatric is just like general, except it's going to be involving children. So a specialized area of dentistry that focuses on providing oral health care according to the needs of infants, children, adolescents, and individuals with special needs. Pediatric guidelines. Please remember this. This is so important, okay? Be honest. Kids know when you're trying to lie to them. You have to be honest. Don't be brutally honest. Pick the right words, all right? Don't scare them. But be honest. The child's point of view, so what are we talking about with the child's point of view? I'm going to take a picture of your teeth, right? You don't have to say x-ray, but you can say, once I'm done taking this picture, I'll print it for you. And you can look at it. And they're like, heck yeah. Okay, hold really still. Here we go. 1, 2, 3, beep, right? No big deal. Always tell them what you're going to do, show them what you're going to do, and then go ahead and follow through with it. Don't ever surprise them. Don't ever do something that you haven't told them that you're going to do. And give positive reinforcement. You're doing so great. We're almost done. We're getting there. You know, whatever it is. Okay, we're going to put the blue shampoo on your tooth, right? The etch. Please don't close down. It tastes really yucky. It's soap. We need you to stay open for this procedure. You're doing great. Breathe through your nose. Always try to stay positive and update them on what's going on. Let's talk about the similarities and differences between adult and pediatric dental treatment. So amalgam and composite restoration techniques are identical, so that doesn't change in adults and children. We still have the same sequencing as far as placing those restorations. Nitrous oxide can often be used in place of local anesthetic. However, it will rarely control an unruly behavioral problem child. So here's the deal, guys. If the child doesn't want to sit in the chair and they're just like throwing down, you do not make them sit in the chair. You do not argue with them. You do not yell at them. You do not fight with this child, because what you're doing is giving them a terrible experience, and you're also causing them to not like dentistry, right? How many of you probably are that person that was a child that was like, I had the worst experience. It was absolutely terrible. We don't want that. We want these kids to grow up and be like, I love it. I love coming here. You know what? Sometimes you have to do things that you don't want to do or that aren't always that fun, but you know it's good for you. And that is the experience we want them to have. We want them to know that we're there for them, that we've got their back, and that they are going to have fun with us, even if some of it isn't the best, you know, possible scenario, like we're getting an extracted tooth. Well, guess what? The tooth fairy comes after that, right? Always land on the positive side when it comes to kids, because we want them to have a good experience. We want them to want to brush their teeth, to want to floss, and to want to come and see us. So keep that in mind. Never force a child to do anything that they don't want to do. Sometimes some doctors will ask the parents to stay in the waiting room, which I never understood until I became a parent why they don't want to, right? But a lot of times, you know, having that experience, the child did better without the parent there, because here's what happens. You'll get that parent that tells the kid, I told you you should have brushed your teeth. Now they're going to give you a shot. And you're like, thanks, right? Why don't you amp them up so they're all freaked out and can't stand us? So obviously we're going to give them a shot. But every time we've given a child a shot and they've trusted us, we have not hurt them. They don't cry. They don't feel a thing because they're relaxed. They're not like adults all tensed up like, oh God, here we go. Let's do this. Like, let's get this done, right? And they're grinding their teeth. Children, we'll tell them to close their eyes. We're going to put your tooth to sleep. You might feel a little pinch, right? We're not going to lie to them. You might feel a little pinch, but it's going to go away quickly and your tooth will be numb. And we go very slow with the anesthetic. And a lot of times they don't even jump. They're so relaxed. They don't feel a thing. So sometimes it is better if the adults can stay in the waiting room, but you will get those parents that want to be with their kids, which is completely understandable. But I would explain to them in the beginning, like, this is going to be a great experience, and, you know, kind of talk to them as if you were talking to the child so they get it. Like, keep your mouth shut. Don't say anything crazy. You know, obviously don't say that to the parents, but you want to make sure they understand the environment that you're creating for the child and that you want them to feel safe. So, and if you have to, talk to them outside of the operatory real quick and just explain to them, you know, we don't say the word shot. We don't say the word needle. This is how we're going to approach the situation, and get the parents' feedback as well. All right, at the bottom here, it talks about endo. We talked about endo usually being a pulpotomy, so it's partial root canal treatment, but we don't ever put gutta percha into that primary tooth because they're going to be losing it anyways. Crown and bridge is usually not performed on primary teeth or really permanent teeth before the age of 16. So the majority of the time, most kids don't need crowns. Every now and then we'll get a child in that has baby bottle rot syndrome, and they've had that sugary milk on their teeth all night and all day, and their teeth start to rot out, which is a very sad scenario. And we do have to put stainless steel crowns on those teeth because the parents just don't realize what the milk is doing. They just don't understand. It's not, you know, hopefully it's really not neglect, and we do end up restoring the teeth that way. Orthodontics is often started as young as ages 7 and 8 into a functional or removable appliance. So we could start widening their jaw, and it could be removable or a permanent appliance, just depending on the patient and what they need. And it's really impressive because they've been able to expand jaws and not need actual braces because they had enough room after they went down that route. So yes, we do start them pretty young now, but there's a reason for it, and there's science to back it up, and it's pretty impressive. Periodontal disease: other than gingivitis, children and adolescents usually do not develop periodontitis and other severe forms of periodontal disease. Okay, your homework. Woo, you made it. That was 100 slides. How'd that feel? Felt good, right? I know you love what you do. Okay, study for your exam. How are you going to do that? I want you to go back through, watch your lab videos, listen to the lectures, your favorite thing to do. You can do it in the car, do it on your phone, do it at home on your computer or your laptop, however you get access to this. Please use the student portal to your advantage. Go back and revisit your quizzes, study your quizzes, get together. If you guys have questions and you're together, it's usually always a good time to email your instructor so we can reply to all of you at once and let you know what you need to work on, or answer any questions that you might have. Don't forget your radiology final appointment and remind your patient what time to be there. Try not to fall behind on time, okay, guys, because we got to get all of these exams done. So definitely keep in mind that you are not the only one taking a radiology final, so make sure to remind your patient to be on time. Have your resume prepared and ready to turn in. Here's the deal. If you don't have it printed, you need to email it in, okay? This isn't something you get a grade for, and we're not going to chase you down and force you. So if you want to get a job, if you haven't already started looking, you need to get the resume turned in so we can help you with interviewing skills as well. I hope you guys have a great day, and I know you will do fantastic on your final exam.